Thank you very much for the opportunity of presenting on this important topic of radiation and contrast management in PCI. So radiation contrast are like the poisons we use in our profession, and why contrast media is deleterious just for the patient. Radiation can also harm ourselves as operators. There are two kinds of radiation injuries. There are stochastic effects that mirror the risk of cancer, and deterministic effects or tissue reaction that hold up those effect relationship, and these are mostly represented by skin injury. So there are hazards for interventional cardiologists due to radiation. There is the risk of cataract and also, although rarely, left-sided brain cancer. However, in the literature, very little information is available on the incidence and epidemiology of radiation injury. This is a meta-analysis of 65 studies in CTO-PCI that supposedly should be the procedure that irradiates the most, and the radiation of skin injury is very critically underreported here, less than 0.01%. So we should do better to report on these important complication of PCI. There is a dose effect relationship, as I just mentioned, between radiation dose and the type of skin lesion. You can have very severe burn-like lesion, like in this case. How can we quantify X-ray dose? There are several parameters like kerma that is measured in gray and represents the risk of deterministic effects because it reflects the amount of dose that arise to the patient's skin. Then there is dose area product or kerma area product that is expressed in gray per square centimeter and represent the risk of stochastic effects such as cancer. And finally, there is the dose rate that is expressed in milligray per unit of time, and this is like the real-time parameter you can control during the procedure. What can we do to minimize radiation dose during PCI? We should first and foremost decrease frame rate. Every time we decrease by 50% the frame rate, we are also halving the radiation dose that we're giving to the patient. So we should try to operate at 7.5 frames per second. Then we should be mindful of fluoroscopic projection, since the radiation dose for the patient is proportional to the thickness of the body volume traversed by the X-rays. So PA projection would be the less radiation, and lateral projection would be those associated with highest radiation dose. So radiation and therefore backscatter into the operator follows the X-ray tube, and we have to keep the X-ray tube away from us. LEO 30 gives a fair amount of radiation, but this increases even more with LEO 60. However, if we go to the other side and we keep the same angulation on the REO side, we will have way lower radiation doses because the tube is away from us. And the same applies to cranial caudal projections. This is a chart that shows clearly that we should strive to utilize projection close to AP, REO projection, and mildly cranial and caudal projections. And this is the concept of the gas pedal I mentioned before. So LEO 45 gives a dose rate of 58 milligrams per minute, but if we just decrease the LEO angulation to 30, we will decrease the radiation dose rate of about 1/3. There is a noise reduction software that can effectively decrease it even by 1/4 or 1/3 the air kermas shown in this study we published a couple of years ago, while preserving the image quality. There are disposable radiation shields that reduce the scatter radiation to the operator, and finally robotic PCI, keeping the operator farther from the table, obviously will decrease the exposure to the operator. We should strive to use fluorosafe function to record ballooning and stenting, use low-intensity fluoroscopy that will reduce the dose rate, and then we have to use the pedal, this is very important, with the left foot, because this will decrease our own exposure, since radiation dose decreases with the square of the distance from the X-ray source. Even 1 foot away will make a big difference for us. And finally, use low mag mode that will spread the radiation dose over a larger patient body area. What about contrast-induced acute kidney injury? We know that this complication has been associated even with mortality. So there are several causes of AKI after PCI, and contrast media is just one of them. There is also kidney hyperperfusion due to hypertension and bleeding, atherombolization into the renal arteries, but for the sake of time in this presentation, we will focus only on contrast media and contrast sparing strategies, intravascular imaging, and contrast removal. I invite you to read this review we published last year in JACC Intervention that summarizes most of the tips contained in this part of the presentation. let's talk about contrast sparing strategies. There are devices that help us achieve this, and we will show you an example in the next few slides. We should avoid pus during coronary cannulation and instead engage the coronary with a wire. We can roadmap it using wires to create a metallic silhouette by wiring key side branches, or use dedicated software. We should try to maximize the use of intravascular imaging, use diluted contrast media, avoid ad hoc PCI, in particular CTO PCI, and in this case, we should strive to use CTO PCI strategies that limit the need for contrast injection, such as the retrograde approach. And for retrograde visualization, we should perform a microcatheter tip injection as opposed to injection through the guide catheter. For diagnostic angiography, we should use smaller catheters, display previous images on the cath lab screens, use, if it's available, biplane angiography, inject just 2 or 3 milliliters per injection, use stent enhancement techniques, and allow the contrast to be eliminated by backbleeding the guide catheter or aspirating before entering the equipment. This is the Diver Plus, that is a device that sucks the excess of contrast that would not contribute to the image quality by sucking it just before it gets to the patient. This is an example how we can engage the coronary with a wire, thus avoiding puffing of contrast during engagement. This is a software made available by Philips called Dynamic Coronary Roadmap that allows us to follow the roadmap during our wiring attempts, or we can achieve the same result by wiring key side branches, and this will provide topographic information that will guide ballooning and stenting. We should maximize the use of intravascular imaging such as IVUS that has been shown to decrease the amount of contrast administered to the patient, and this has been brought to the extreme by Ziadali's group that reported on the feasibility of a zero contrast PCI protocol based on IVUS. We can also use OCT, this time replacing the contrast media with dextran-based flash, and this will provide pristine image quality, very similar to contrast-based OCT. This is an example of very decent image quality achieved with diluted contrast that will decrease the contrast volume by 50%. And finally, when should we consider to stop the procedure? There are international standards for radiation dose, a kerma error product of 500 gray per square centimeters, or error kerma of 5 grays. And for contrast, a contrast volume to creatinine clearance ratio above 3 or 3.5 according to different studies, or even greater than 2 in high-risk patients. Summarizing, radiation and contrast are the poisons we use in our profession. We should learn our X-ray equipment and basic principle of radiation protection. We should be cognizant of the risk of AK after PCI, and contrast media is just one of the causes. We should learn and implement contrast sparing strategies and intravascular imaging. And finally, you don't need to use all the possible strategies outlined in this presentation. We should just learn and use what works for you, develop a protocol, and then stick to it methodically. Thank you very much for your attention.